Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on biomarker testing and selecting targeted therapies for patients with advanced non-small cell lung cancer. This episode is part of a larger educational program titled New and Evolving Therapeutic Targets in Lung Cancer. Expert guidance in incorporating biomarker testing to deliver precision therapy. During this podcast, Dr. Edward Kim from the Levine Cancer Institute in Charlotte and Dr. Leora Horn from the Vanderbilt Ingram Cancer Center in Nashville will answer questions asked by the audience during a live webinar on such important topics as approaching discordant results with liquid versus tissue biopsies, resistance to TKIs and repeating testing at disease progression, and selecting therapy for lung cancers with alterations in ROS1, EGFR, MET exon 14 skipping mutations, or RET. For more information on Dr. Kim and Dr. Horn, along with a link to the complete program, including a downloadable slide set and a downloadable PDF of key points from this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Welcome, everybody. It's really great to do this together with Dr. Horn.
So we have a few questions that have come in. So one of the questions that has come in is it clinically meaningful to use a large panel of genes for NGS if we don't have all the therapeutic options for all the actionable mutations that can be reported?
Yeah, I like that question. And I'm sure you guys at Vanderbilt also had to sort of debate this. Early on, when we only had a handful of markers, we thought it was very reasonable to have a smaller sort of a smaller platform. But now, I mean, the way things are changing, frankly, we are actually moving from our in-house smaller platform to a commercial larger platform. So it doesn't seem like so much extra anymore because the platforms are a little bit different and it's tough in-house to do it quickly. So even if we did everything in-house, it would still take 7 to 10 days and we don't really gain anything. So I like the larger platform now, and that's what we're transitioning to. I don't know if you guys are doing the same thing, or maybe you've already been doing it at Vanderbilt.
Yeah, we actually started about a year ago when Ben Park came to Vanderbilt, and I think he made a smart decision, and I've heard that Emory's doing something similar, where rather than spending institutional dollars on developing a new platform, because the platforms keep changing, let the companies do that, and we'll send out and partner with them. It's sent out. We have access to their interface, so we can tell where the results are when they're coming back. So it's actually been quite helpful to have, and we have quick access to the data that way. I have another question that came in. If a patient is negative on one platform, do you choose a different one?
Yeah, we as long as if it's tissue, we don't. If blood was done for some reason or some, then it might be done. But they also have that you draw blood at the same time as tissue. So if something goes wrong with the tissue, you can default. But I don't usually biopsy somebody multiple times if I'm wondering about a marker. I've done that with diagnoses, but I haven't done it with marker per se. I don't know. Have you done that?
No, I haven't, and especially if people know what platform they're using, and if it's DNA versus RNA, the RNA is a little bit more sensitive, and that's what we have available to us now. The DNA, there's some data that maybe you're going to miss some of the fusion partners to the DNA test that you'll capture on the RNA. But I don't generally, if blood is negative, I agree with you, then you do have to go over tissue again. So one question is, what do you do if you have to start treatment on a patient and you can't wait for their molecular results to come back?
Yeah, I haven't found many of that occurring. Chemotherapy is not that good. And frankly, if the biomarkers with the targeted therapies we have given much more robust responses earlier, quicker, et cetera. And so I really, I just think we have to wait. It's ironic, when I was at MD Anderson, patients would end up seeing their local provider, and then they would get a second opinion. And then by the time they came and saw us, and they were usually with us at least a week, and then went back, it was a month or a month and a half. So, I think we can wait. It's just hard when there's pressure. And when you're diagnosed, I understand as a patient, you just really want to get started, but it is really important to wait.
Yeah, I completely agree. And the one thing I do tell people, if you have to start it, just leave out the checkpoint inhibitor until you have those results because of the data that you've shown with harm. So in a patient with EGFR mutant positive disease and a PD-L1 score of 80%, failing first-line osimertinib, what's the recommended second-line treatment?
Yeah, the academic answer, I feel, is the Empower 150 data, where you use the combination chemotherapy with bevacizumab and the atezolizumab, and you have a lot of great experience and have published extensively with atezolizumab. I have not found I've had to use it that much, but that would be sort of one choice. I think the benefit is that the wild card is that angiogenesis aspect that somehow can overcome the negative with the checkpoint inhibitor. So that's usually what we consider.
Yeah, and to be honest, I'm more likely to just give the Bev and forget about the, carbopem bevacizumab, still one of my go-to regimens. But the data is interesting. I think the problem is the trials that are being done, we may not get that answer because the trials that are being done in the EGFR resistant patient population they're doing carbopemetrexate and pick your checkpoint inhibitor versus carbopem alone. So we won't even see that additive potential benefit of bevacizumab, but hopefully we'll get data on that in the next couple of years.
Totally agree with that. Yep. There is one question I think that's relevant to your section here. It is a question that is about ROS1. Which ROS1 inhibitor would you use in first line?
Yeah, that's a good question. I think I used to go to crizotinib when it was originally, my choice was crizotinib or ceritinib, primarily because I thought crizotinib was a better tolerated drug than ceritinib, and because the ceritinib CNS data wasn't as good. Now if I have a patient, my first line agent is generally entrectinib. I find that the entrectinib is well tolerated. I have had to dose reduce one patient because of some of the dyschezia, dizziness, the neuropathy that they experienced. However, I also do that thinking about the CNS, knowing that many of these patients will develop CNS disease and trying to both prevent the development of CNS disease. I think if a patient didn't have CNS disease, it would be reasonable to do crizotinib or entrectinib, but if they have CNS disease, entrectinib is definitely my treatment of choice.
Yeah, I can't disagree. It's the same. We were part of the Star Trek study, and entrectinib has been, you kind of get attracted to these newer drugs as long as there aren't more side effects. And then one other question was, is there data regarding point mutations in NTRK fusion harboring tumors?
If you had an NTRK point mutation, I haven't really seen that in patients on prior to starting therapy, but I would imagine we're going to start seeing that, similar to how patients with ALK rearrangements develop ALK mutations as a mechanism of the resistance to their ALK TKIs, and patients who are ROS1 positive and on the ROS1 inhibitors and develop ROS mutations as a potential mechanism to their TKI. I would imagine that as more data and we see more patients, that patients with NTRK are so rare. I have 2 in my practice, and often I'll talk to people and they don't have any. And so with time, I think we'll learn more about the different mechanisms of resistance and which NTRK inhibitor that is currently approved can you target that specific resistance mechanism. Have you seen any patients yet, Ben, Ed?
Our system had 5 last year. I had 1 on the Star Trek protocol. But I agree with you. They're very hard to find, and even depending which testing platform you use, they don't always test all the variants either. So it is very challenging to find these folks.
And was that patient, they had an NTRK mutation and entered on study, or it was their mechanism of resistance to the entrectinib?
Oh no, that was upfront. So yeah, it was a second or third line patient, but we found a tract fusion, and so we treated them with entrectinib. So it was not a resistance. So okay, very nice. There are quite a few questions. I want to be mindful of time. So one is, what is better for CNS penetration, larotrectinib or entrectinib?
You know, the numbers are small. The response rate with entrectinib is around 50 to 60% with CNS disease. Larotrectinib was 71%. I don't think that we know enough to say definitively one. I will say, hearing patients talk, and I'm curious to see what you think, Ed. I've heard several patients say that larotrectinib is easier a little bit in terms of toxicity than entrectinib. I've also seen that larotrectinib, my Canadian brain, and thinking about cost, is less expensive. But in terms of efficacy, I think that they're fairly similar. It's hard to make clear judgments across different trials with only, you know, out of the patients enrolled in the study, only 20 of them had CNS disease. So, you know, those numbers are so small.
Yeah, I wouldn't disagree with anything you said there. There's definitely, you know, the amount of experience that personally you have is very low, and then you can only rely on the data out there. But that's kind of what I get as a gut feeling too, as with the side effects, as you stated. And then there was one question about brigatinib in ROS1 positive. Your opinion? Not
a drug that I would go to. You know, I think that there are other agents out there. You know, if your patient's been on crizotinib, lorlatinib, I'm not going to go to brigatinib. I would try find them the repotrectinib study. I think that that's the most promising drug for that patient.
Yeah, no, that's great. And then the last was, would you consider ceritinib in ROS1 mutant patients failing crizotinib or lorlatinib?
Probably not after lorlatinib, based on the data that we saw with the ceritinib study. Patients who were on crizotinib did not appear to have a great response to ceritinib, and one would imagine after lorlatinib would have a similar thing. I might sequence them, look for this novel mutation that Jessica Lynn reported on, and cabozantinib could be an option for that patient. But I would try find them a clinical trial or repotrectinib if you're able to get it.
Yeah, no, I think that's great. Okay, all right, a lot of good questions.
Sure, you know, it's fascinating. There were 7 drugs approved for lung cancer in May. So anyone keeping track of them it's a tough thing to do. But it's nice to see targeted therapies emerging again, because I feel like for a long time we've been overridden with immunotherapy. So this actually goes back to your original discussion, Ed. So I might do this one first. If you were testing both blood and tissue, what do you do if there's discordant results?
Yeah, so, you know, we don't generally like to test them at the same time. We'll usually do them in sequence if needed, but tissue is usually what I believe mostly. And so that's where I still put my sort of credence in. However, it just depends on what the situation is and whether you're double checking, et cetera. But most notably, you're trying to get tissue if you can get it. So that's what I usually believe.
Yeah, me too. And, you know, and again, think about what your test was, whether it was an NGS versus a PCR test. I think that's important to remember as well. So another question, how likely do you think KRAS mutations are going to become actionable in the near future?
I'm really excited about KRAS. I mean, I'm excited about all the other stuff too. I mean, you know, RET, MET, you know, HER2 mutations, gosh. But I'm really excited about KRAS because there seems to finally be some drugs that have real activity. You know, there were other drugs in the past that we were trying to eke out responses and really say, oh, it looks like it's better. I mean, this actually looks like something actionable finally. And so I'm very optimistic about KRAS. I'm hopeful because that'll be a huge impact, 25 to 30%, you know, when you test those positive. I mean, that would be huge. Again, less with the G12C, but still, I'm very hopeful.
Yeah, me too. I think I can answer this next question for you and spare you for what about MET mutations, what's standard of care. When we were talking about MET, we're referring to the MET exon 14 skipping mutation. So capmatinib is currently, in my opinion, standard of care. crizotinib's there and tepotinib. How often would you expect to repeat an NGS test upon disease progression, and how often do you think it's useful?
Yeah, I think many of us, especially when we see progression, we like to sort of retest, especially when it's new disease that's appearing. I want to get a biopsy and I want to see if there's something different about that, because we don't want to abandon therapy that may still have activity on the current tumor. Now, again, the data that's been put out there with progression in EGFR, even with that small cell transformation, I think many of us are like, wow, we don't want to miss that. That was 12 to 14%. So I like to rebiopsy upon progression, and I like to retest for markers just to get a sort of a new baseline in folks.
Yeah, we do the same, and that's where we'll often start with blood. If a patient doesn't want to have a tissue biopsy, but if the blood doesn't help us, then sort of convincing that a tissue biopsy will be useful.
So here's a question. How do you sequence a RET inhibitor? Could you use pralsetinib or cabozantinib after selpercatinib?
I'm really glad you're asking that question is being asked, because I don't have enough experience to say yay or nay. I don't know if sequencing will work. It seems we always try it no matter what, and it depends on how the progression is, right? So if you had someone who had activity and their tumor shrunk, and then they went into this sort of stable and then slow progression, okay, maybe you can try a different drug and see if you can get that bump down and, stabilize things. If someone just didn't respond and progressed quickly, it's unlikely another one's going to help. And that's the way I would kind of weigh it. You might know the data better than I do if there are studies studying that now, but I think it'd be challenging right now to have those studies.
No, I agree. And the majority of the studies excluded patients who had a prior X inhibitor. So it may take years of the drugs being out there for us to really learn, and lots of biopsies to, look for mechanisms of resistance and understand that.
Thank you, Leora. You're great. It was a great discussion tonight. So.
Yes, thank you. Have a good night.
Thank you very much, Dr. Kim and Dr. Horn, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, New and Evolving Therapeutic Targets in Lung Cancer, Expert Guidance in Incorporating Biomarker Testing to Deliver Precision Therapy, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. Thank you.